Now, we have discussed about the diseases to stomach and duodenum. The next part is about the liver and the biliary disorder. Liver is a huge organ of the body, and it has a very complex process. And anatomy of the liver, of course, you know about it. Like it has the two lobes, right and left lobe, and the third lobe is a caudate lobe, which is also important. The important, of course, we will not go much into the detail of that anatomy issue now. The primary functional entity of the liver is a hepatic sinusoid or hepatic cell asset, the unit asset, and that hepatic unit would have a central vein where the blood vessels would be receiving the blood, and then the cells are arranged in a circular fashion. The portal veins, the portal system, the hepatic artery and the hepatic vein, that would be having that, and then of course the biliary duct. These three are together at the hexagonal area, at the angle of that hexagonal area. A unit of hepatic cell or hepatic globule is a hexagonal structure, and it has a central vein, and in between we have the sinusoids. Now the hepatocytes are layered over the sinusoids, and this kind of a complex system is considered as a unit of a liver function, like hepatic globule having a vein, central vein, which ultimately drains into the portal system, then hepatic artery, and then the biliary duct as such, and hepatic veins. The blood would be accumulated from there. The blood will be flowing from the artery towards the central vein, and in the central vein it gets drained out, and again it gets circulated into the portal circulation. So portal circulation is the important issue there. And in the liver hepatocytes layer, the sinusoids would have the hepatocytes arranged peripherally, which will take care of the biochemical functions of the liver, and the sinusoidal endothelial cells, they would also protect or help in engulfing phagocytosis. Kupffer cells are the other cells which are important from the immunological point of view. They are the ones which can do the phagocytosis effectively. So liver has multiple functions as such. The functions of the liver are again huge, and virtually every biochemical activity of the body would have some role to play with the liver at initial stage or the later stages. For the sake of convenience and for the sake of practical clinical utility, we classify these functions into mainly synthetic functions, and we use the albumin synthesis, one of the major substance which is synthesized by the liver, as one of the biochemical parameter for the study of the synthetic function. It also synthesizes many other substances, and among them another one more is the clotting factors, particularly prothrombin, which is synthesized by the liver, and that prothrombin time also is considered as one of the liver function tests. Then it secretes substances by modifying that, it chemically modifies certain substances and helps in the secretion of that. One of the examples there would be the bilirubinin, which is a byproduct of the hemoglobin metabolism, is converted into a conjugated form, water soluble form, and then it is secreted out, and that's again used for a study of the secretory functions of the liver. Of course, it doesn't mean that the liver secretes only the bile as such. It secretes many other substances. Bilirubin is only one example. Similarly, it also helps in secretion of the cholesterol. At the same time, it secretes certain of the substances either by modifying or synthesizing in, and certain of the substances are not modified, and simply they are secreted out as such, and excreted out as such. And among those excreted substances, alkaline phosphatase is one of the important issue, which is used as a biochemical parameter for the study of the liver function. So excretory functions of the liver are studied by the biochemical functions of these of course from excretory biochemical functions, we use the alkaline phosphatase as a parameter, or many times you may use any other exogenous dye. In a very advanced status, you may give the phenolphthalein, and phenolphthalein excretion also can be studied as a liver function test. It detoxifies many chemicals. Many of the chemicals are detoxified, among them thyroid hormones, steroids. Steroids is one of the important substances which are detoxified by the liver, and this also can be used as a liver function test, though not used regularly. It has a metabolic function. The metabolic function would be mainly a metabolism of carbohydrate, lipid, and almost every metabolism would have a role to be played by the liver. And particularly, the most important is the interconversion of amino acids. Aspartate amino acids and pyruvate amino acids, they are converted into the other. Transamination reaction is one of the important functions which we use to study the liver function test. Now, when we go into liver function test, we will have more discussion about that part also. It also stores the glycogen. When glucose metabolism, liver has a very important role. When the glucose is in excess, more than what's needed, that is converted into glycogen and it is stored in the liver. And whenever there is a need for new glucose, the glycogen is broken down, there is neoglucogenesis occurs, and the glucose is supplied to the body. And hence, liver also has a major role to play in maintenance of the sugar level in addition to the insulin. So, insulin, of course, is one of the hormones which does this reaction, and the reaction is mediated through the liver also. Now, based upon these functions, we mainly depend upon the liver function test. Now, liver function tests as such can be innumerable. There is no end to the liver function test. But for all practical purposes in the routine clinical practice, we limit the liver function test to these 6 as such. And those are assessment of albumin and the total protein, alkaline phosphatase, and alanine transaminase or SGPT, glutamate pyruvate transaminase. Now that SGPT or glutamate pyruvate transaminase is a transaminase is a old nomenclature, or alanine transaminase is a new nomenclature. In brief, it is also mentioned as ALT. And aspartate aminotransferase are glucose oxalate transaminase reactions. Glutamate oxalate transaminase, these enzymes. Bilirubin is mainly for the detoxification. Sorry, there is a spelling error. It's not S, it should be the detoxification function. The bilirubin is studied. Prothrombin also is studied as a synthetic function. These are the very frequently done liver function tests. But this is not the end of it. In specific cases, you may have to go for more specific study of the functions, and that's limited to only the specific cases. But routinely, when we say liver function test, we limit to these tests as such. Now, when it goes to the interpretation of these tests, certain of these are quite important from the practical clinical point of view. Now, coming to that SGOT or ASD and SGPT, SGOT is present in large quantities in the liver cells, heart, muscles, kidneys, brain and pancreas, as well as RBCs. And the SGPT is present mainly in the liver, kidneys and heart, as well as to the extent of muscles. The level of SGOT, normal level, is 8 to 48 units, whereas SGPT, the level is 7 to 45 units per liter. And the normal ratio of this is 1 is to 1.15. So, that's the normal ratio. Among them, SGOT is more specific for study of the liver functions than SGPT. SGPT may be raised in myocardial, renal and muscular diseases also. The interpretation of this has a very clinical significance. When the ratio of SGOT SGPT has been raised to be above 2 and up to maybe around 6 or less than 6 in that range, 2 to 6 range, the ratio is raised, that's usually a sign of alcoholic liver disorder. Whereas a toxic hepatitis produced due to organic substances, the ratio would be less than 2 as such. Then in case of cirrhosis, the ratio would be 1.4 to 2.0, it's altered. In cholestasis, intrahepatic pathologies, it's actually raised, but it's less than 1.5. And whereas in extrahepatic cholestasis, that obstruction, it's essentially more than 1.14. Of course, normal, as we have told earlier, 1.15. And the chronic active hepatitis, in case of chronic hepatitis, the ratio is 1:3, and extrahepatic biliary obstruction, it's 0.8 as 0 to 8 the ratio, and acute viral hepatitis also the ratio is 0.5 to 0.8. This ratio is these ratios of the SDOT SDPT also is one of the important issue. One more is because SDOT SDPT are present in the unit cells, when there is active destruction of the cell, the level of these transaminase levels enzymes would be raised. When the transaminase level raises very high, like more than 600 or 700, that suggests you of acute viral hepatitis, where there is an extensive damage to the liver cells. Whereas when the level is in between 100 to 200, just moderately raised, that suggests you of either a chronic hepatitis, or even in case of the alcoholic liver disorders like conditions, it will be in the middle range. So that information of the levels of the SDO, the SGPT would be helping in making the diagnosis as such. The next is about the bilirubin analysis. Bilirubin, as you know, physiologically, the bilirubin is produced from the RBC destruction. RBCs, when they have ended their utilitarian life, they are destroyed, and they are destroyed by the spleen as well as to a certain extent by the liver, and the components are separated. Particularly the heme, now that protein molecule, globulin molecule would have a different course. The heme, which contains iron, is destroyed or broken down into a biliverdin, and iron is separated. That biliverdin is actually a water insoluble substance, and that biliverdin is converted into a conjugated bilirubin, or biliverdin also is named as unconjugated bilirubin. It's made water soluble by combining it with the glucuronic acid, and it forms the conjugated bilirubin. So liver, it has a major two levels of function. One, the synthesis of the biliverdin, and then biliverdin getting converted into conjugated bilirubin, or making it water soluble. So water insoluble and water soluble. For the proper excretion through the bile, it has to be water soluble, and that function is done by the liver. Now, because of these kinds of levels of function, the importance of this study would be, when you get into the laboratory studies, when you will get the report like a direct bilirubin and indirect bilirubin. The direct bilirubin is a conjugated bilirubin. That's when the biochemical reaction is made in the laboratory. The results you get directly by assessing the water soluble bilirubin is the conjugated bilirubin, or that's we use the word direct because the result is seen by the processing the solution in water. Later on, you add some alcohol substances which can help in making that water insoluble bilirubin to be seen, and that's what we call as the indirect bilirubin or unconjugated bilirubin. So when you refer a patient for the study of bilirubin studies in the laboratory, you get the two stages results, the direct bilirubin and indirect bilirubin. Direct bilirubin suggests about the conjugated one, the ultimate end product. Unconjugated is the intermediary product, which is water insoluble, and or it's also called as indirect bilirubin level. Now, interpretation of these results in the clinical practice would be, if there is an unconjugated bilirubin level increased than normal, above normal, then it's also called as a prehepatic jaundice. Now, of course, jaundice is a clinical condition where the bilirubin level is more than 4 mg/cent. Clinically, jaundice is seen, yellowish discoloration is seen is when it's more than 4, and when it is in between the 1.6 to 4, we call it as a subclinical jaundice as such. Anyway, now whenever there is a rise in unconjugated bilirubin, that suggests that either there is a overproduction of this unconjugated bilirubin, that's a hemolysis would occur, as in case of hemolysis where the RBCs are destroyed more rapidly than the usual, or the capacity of the liver being reduced to convert that unconjugated to the conjugated, there will be accumulation of this backlog of unconjugated bilirubin. So that's in such conditions where the blood supply to the liver is affected, it also can result in an unconjugated hyperbilirubinemia. The bilirubin level would be raised. When the conjugated bilirubin level is raised, is always suggestive of an obstruction to the biliary system. It's also called as post-hepatic jaundice or obstruction. So if the bile flow somewhere is obstructed, there would be backflow of the bile which is finally synthesized by the liver, and hence the unconjugated bilirubin gets reabsorbed into the system, and hence you may have a unconjugated bilirubin level raised, and whenever there is a significant raise in the unconjugated bilirubin level, that's suggestive of a post-hepatic jaundice or obstructive jaundice. Whereas if there is a biphasic, both conjugated and unconjugated are raised, and maybe the conjugated bilirubin is slightly lesser than the unconjugated, then it's called as a hepatic jaundice, which is produced due to a liver pathology, where the liver is neither able to convert the conjugated bilirubin efficiently and nor excrete that conjugated bilirubin efficiently. So efficiency of the liver being reduced, that's what we call as the hepatic jaundice. So that interpolation of the liver function test is important. Of course, the albumin is mainly to assess the synthetic function. If the albumin level is reduced, that suggests about the synthetic function being reduced as such or affected by the liver. And albumin globulin ratio also is studied as a parameter to study the liver function test, when because the globulin is synthesized by the lymphatic system, albumin is synthesized by the liver, and there has to be a normal ratio of 2:1, and if at all this is altered, you may compare the liver function to the functions of the lymphatic system, as well as it may indirectly it may give you an interpretation of the liver function test. That's about the issues. With this basic idea about the liver function test, the other important investigation which could be useful in case of the liver pathology would be ultrasonography, because ultrasonography can give you a very clear picture about the consistency of the liver tissue, and mild alteration in the physical consistency of the liver tissue can be better studied by the ultrasonography. So that's another of the useful investigation in case of the liver pathology. Now, in which of the conditions, which of the investigations have to be used, we will go into the next part. Now, directly going into the diseases, the first of the disease which I would like to deal with would be the viral hepatitis, a inflammatory pathology of the liver produced due to the virus. Of course, since a long time historically, the epidemics of jaundice were known, and the epidemics of jaundice were named with the different entities. A virus being responsible for that is a very recent one. It's something like only in 1942 that the first virus was identified as responsible for the hepatitis, and in 1947 the clinical identification of the two types, A and B, was done, and the differences in their course of the disease is made out, and in 1963 a Australia antigen, a specific antigen of the hepatitis B virus, was identified, whereas the hepatitis A virus, the discovery of the hepatitis A as a separate entity and establishment of its all that physical features was only in recently, that's 1973, and of course a possibility of virus culture and hepatitis virus culture was later on done, and the hepatitis A vaccine, which has significantly reduced the incidence of the hepatitis, was invented only in 1992. So it's a very recent development. Incidence of the viral hepatitis A is quite high in our country. India is one of the area where the incidence of the A hepatitis virus is very significant, and it's one of the major health concerns in India. Incidence in Western developed countries, of course, has reduced to a great extent after the invention of that virus as well as the lifestyle factors, but currently it's again on the rising edge as such in the Western developed countries. Incidence of viral hepatitis has a seasonal this epidemic, it has a seasonal factor. It's common in the winter months like January, February, as well as again there would be a peak in June, July. This is the usual course as such, or somewhere in summer also you may have these epidemics. So viral hepatitis has a very significant presentation of the hepatitis A has a pattern of seasonal episodes, epidemics, like. And the causes for the hepatitis, viral hepatitis A, are considered to be mainly the poor sanitation, and it's supposed to be transmitted through the water, and hence a safe water absence or insufficient supply of the safe water also is considered to be one of the important causes. And of course, physical contact with a infected person. Now, when we say the physical contact with the infected person, it's through the fecal-oral route that it gets transmitted. It's not by direct transmission like the touch or maybe the serum. Whereas hepatitis B is transmitted through the serum, whereas hepatitis A doesn't get transmitted through the air breathed out or physical contact, but it will be transmitted through the fecal-oral route when there is a contamination of the food source by the fecal excretion of a patient, or the organisms are transmitted. That produces the transmission as such. And of course, it also can be produced during the sexual intercourse. Initially, it was believed that only the hepatitis B virus is transmitted through the sexual activity, but now it is known that A also can be transmitted through the sexual activity. The certain of the drugs, particularly so-called recreational drugs, like which are addiction-forming drugs, including alcohol, increases the incidence of the hepatitis A. Homosexual behaviors also are the other causes for the hepatitis A. And of course, if there is an endemic area, and in that endemic area if there is a traveling, then also the hepatitis A is a possibility. WHO has given a major series of guidelines on hepatitis A, and those guidelines are, it's of course defined as an inflammation of the liver that can cause mild to severe illness. Hepatitis A virus is transmitted through the ingestion of contaminated food and water or through direct contact with the infectious person. Almost everyone recovers fully with the hepatitis. This is important. Hepatitis A has a mild course, and almost 100% patients would recover well without any direct intervention, and there is a lifelong immunity. This is what the WHO says. But we have seen plenty of patients who develop hepatitis A repeatedly, even though they had some established disease entity earlier. So it may be supposed to be due to the mutation, but as per the WHO guideline, it is supposed to have a lifelong immunity. But of course, it says that, however, a very small proportion of people infected with hepatitis could die from fulminant hepatitis. Though the outcome is usually good and the course is mild, rarely some patients may have fulminant hepatitis and it may result in fatal conditions. And the risk of hepatitis A infection is associated with lack of safe water and poor sanitation and hygiene. So mostly the incidence of hepatitis A occurs in winter, at the end of rainy season, because of the contamination of the water. And a safe and effective vaccine is available to prevent hepatitis A. Hepatitis A can be prevented as such. Now, the pathological entities of hepatitis A is once the infection occurs, the symptoms may not occur immediately. There is always an incubation period. The incubation period may be up to 1 to 2 weeks. So first 1 to 2 weeks, there may not be any symptom, no change in the physical activity as such. The virus will grow, the number of virus will grow usually by second week, and it may continue up to about 4 to 5 weeks. So up to 4 to 5 weeks, the real viruses will be seen in the body, in the blood. But viruses in the feces may continue up to about 6 to 7 weeks. So that's the important issue. So a patient with viremia, where the virus is seen in the blood, it's only for about 4 to 5 weeks. Next 2 weeks, the patient may have a relief of symptoms. Viremia is reduced, the patient may not have the symptoms like fever or so on. And the patient may continue to excrete the virus in the feces, and hence the patient can be a carrier of the disease and can transmit the disease up to about 6 to 7 weeks. The biochemical levels of the transaminase level would be raised, that evidence of the liver destruction would occur only at the end of viremia, initial stages of viremia. That's the first 2 to 3 days of the viremia. The transaminase level may not be raised in usual courses, but in a fulminant one, it may increase as such. So transaminase levels will be raised later. Symptoms of jaundice would occur only after about a week of viremia. So initial first 1 week, 1 to 2 weeks, there will be no symptoms, incubation period. In between 2 to 4 weeks, the patient may not have jaundice, but he may have the symptoms of viremia like fever, pain in joints, and so on. The real jaundice will occur at the end, maybe around the third to fourth week as such, and the jaundice may persist for about another 1 to 2 weeks as such, 2 to 3 weeks it may persist. The immunoglobulin, the issue would be immunoglobulin M would be raised by about the 6th week, by the time the clinical relief has occurred. Now, by this time, the patient may be clinically normal, there will be clinical resolution, and at the time, IgM level may be raised and it may continue to be there about 14 weeks. Immunity produced to immunoglobulin G, it can remain for a long duration, and even beyond 14 weeks it may be there. This is the usual time course of hepatitis A infection, and this is different from hepatitis B. So when we go into the hepatitis B, you will find the difference there. Now, clinical symptoms of hepatitis A are in the moderate average cases. The initial symptoms are mainly anorexia, nausea, vomiting, etc. Something related to the GIT, which are vague symptoms. A low-grade fever, myalgia, a fatigability or exhaustion also are the other common clinical symptoms as such, which again may not be able to be, and this can start after the incubation period and may continue for about 1 to 1.5 weeks. Till the jaundice occurs, it may not be identified as such. Altered smell sensation is the other very characteristic clinical symptoms. Often the patients may say that their smell sensation is altered, and particularly smokers who smoke would have an extreme intolerance to the smell of the smoke, and that's very characteristic. It's well recorded. One of the well recorded clinical entity is aversion to the smoking in a person who is a smoker. Of course, a person who doesn't smoke, it's not relevant, but exact reasons for that are not known, but it's a well recorded entity. Like a person who is otherwise a smoker, and he develops a aversion to the smell of the smoke, possibly he may have a viral hepatitis. That's not that it's always true, but this is well recorded. And then epigastric pain, or the pain in the right hypochondrium, either intermittent or mild, or maybe at times moderate. The variation could be there. That's also another characteristic feature. Once jaundice occurs, clinical jaundice occurs, the diagnosis is evident. Till that phase, the diagnosis of hepatitis A is not very evident. Till the jaundice occurs, it may not be possible to make out the diagnosis easily. In rare cases, this is the usual course of the moderate, and usually the patient would have a relief of the symptoms by about 3 to 4 weeks, and usually by 4th week the patient may be normal clinically, or maximum 6th week. Whereas in a case of fulminant, which is not very common, rarely a fulminant ones, it may be suddenly presenting with hepatic encephalopathy, and its symptoms we will discuss later on when we go into the acute hepatic failure, and it also can present with somnolence, that's moving at night, or disturbed sleep, that disturbed sleep pattern, which itself can result in somnolence. This also is well known, and mental confusion. Now, these issues often may look like a psychiatric condition. Hello. And ನಂದು ಇದು ಸರಿ ಉಂಟು ಸರಿ, ಇಂಟರ್ನೆಟ್ ಬ್ಲಾಕ್ ಆಯಿತು, ಒಂದು ನಿಮಿಷ. ಎಷ್ಟು ದಿನ ಸ್ಟ್ರೈನಲ್ಲಿ ಬ್ಲಾಕ್ ಆದ್ದು ಗೊತ್ತುಂಟಾ? ಸರಿ 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 ನಾನು ಇಂಟರ್ನೆಟ್ ಬ್ಲಾಕ್ ಆಯಿತು, ನಾನು ಈಗ ಚೇಂಜ್ ಮಾಡ್ತೇನೆ. ಇದು ಬರ್ತಾ ಉಂಟಾ? ಈಗ 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 ನೋಡಿ ಈಗ ಬಂದದ್ದು ಬಂದಲ್ಲ ಈಗ ಸರಿ ಅದು ಇಂಟರ್ನೆಟ್ ಬ್ಲಾಕ್ ಸರಿ ಓಕೆ ಆಲ್ ರೈಟ್ ಐ ಥಿಂಕ್ ದಿಸ್ ನೌ ಇಟ್ಸ್ ವಿಸಿಬಲ್ ಸರಿ now that's about the immunoglobulins. I think this slide was clear. Immunoglobulins that IgG level would be there for a long time. Now in clinical symptoms of this viral hepatitis A would be in a moderate conditions or the average conditions, the symptoms will be, the initial symptom will be anorexia, nausea, vomiting, low grade fever, myalgia, which are seen after the incubation period and they may last for about 1 week. Jaundice is the last symptom to occur and usually it takes about 2 weeks to start with the jaundice. Till the jaundice is seen, it may not be possible to make out the diagnosis accurately by the clinical evidences. It's the biochemical evidences also like the transaminase level may not be raised immediately and hence during this phase the diagnosis is difficult in patients of viral hepatitis A. And once the jaundice occurs, of course, it may be seen as such easily. Whereas in a fulminant patient, the patient rarely, which occurs, fulminant patients, it may occur rarely, where the patient may have encephalopathy, which we will discuss later on, somnolence, disturbed sleep like sudden loss of sleep and mental confusion, etc., which may give a confusion with the psychiatric issues. Patient may even go into hepatic coma. Patient may develop ascites, GIT bleeding, and bleeding disorders may be the other symptoms as such. That's in case of hepatitis A. Now, the other variant of the hepatitis is hepatitis B. The B virus is according to WHO, it's a viral infection that attacks liver and causes both acute and chronic conditions. It's more virulent. B is more virulent. And it is transmitted either during birth from the mother to the child or it may be transmitted through the blood or other body fluids either during sex with an infected partner or unsafe injections or exposure to sharp instruments can result in the hepatitis B. So hepatitis B may not have a seasonal episode, it may not have an endemic nature as in case of the hepatitis A, but it can occur within a group of people who are in a physical contact and then tend to spread rapidly. And the incidence of hepatitis B is now increasing very rapidly, and according to WHO, more than 296 million of people are living with the chronic hepatitis in 2019, and with 1.5 new infections added every year. Now, with all that precautions, all that awareness of the hepatitis, still that incidence of hepatitis B is increasing. That's a very important issue. And hepatitis B also is, because it's a critical condition, it has resulted in more than 8 lakhs deaths by 2019, and mostly from cirrhosis and hepatocellular carcinoma later on. So about these issues also we will discuss somewhat more. So hence hepatitis B is of more virulent nature and more issue of concern than hepatitis A. B can be prevented with vaccines and that are safe. Incidence of hepatitis B is increasing, reducing every year, and by 2012 in the USA the incidence is reduced. But whereas in India also, it has reduced remarkably compared to the previous years. So incidence of hepatitis B is effectively reduced by effective immunization as such. Now, presentation of hepatitis B, the only issue is otherwise it's very similar to hepatitis A, except for the fact that the incubation period is shorter, usually 4 to 5 days or less than a week, and the clinical symptoms are more rigorous. Jaundice occurs earlier, and hence the clinical symptoms they may occur more vigorously. In addition to that usual presentation, otherwise it's exactly the same as that of the hepatitis A. There will be more severe clinical symptoms, more severe fever conditions, and the jaundice also would be quite deeper. The other clinical symptoms which may occur, rare presentations may occur, could be pleural effusion with the portopulmonary syndrome. Now, portopulmonary syndrome, what is it? We will discuss later on when we discuss about the cirrhosis. Then intravascular coagulation which with the fulminant hepatitis also can occur in patients of hepatitis B. Patients may present with cardiac symptoms like myocarditis, pericarditis or arrhythmia also may occur in case of fulminant hepatitis. Patients with severe arthralgia and subcutaneous fluids also may present with hepatitis B. Hepatitis B patients also can present with Guillain-Barré syndromes, encephalitis or meningitis-like symptoms. Pancreatitis also can be seen. Aplastic anemia also it may be one of these. These are rare clinical presentations of hepatitis B. So whenever you have patients with these clinical presentations, one of the differential diagnoses you have to keep in mind is a hepatitis B as such. The pathological course of the disease and the clinical symptoms as such would be slightly different from hepatitis A. The patients have incubation period which is less than a week. The clinical presentation would occur with initially the raised ALT, that the SGPOT level would be raised remarkably, and the clinical symptoms would occur at the end of a week or so. So that's the usual thing, like so this is a period, and it may, that ALT may be raised for about 4 to 5 weeks, even beyond that. So that's the usual course. It can be prolonged. Now, hepatitis B is mainly identified by its antigen, HBsAg and HBcAg, the core and the surface antigen. Surface and core antigens are the two important parameters to make the diagnosis of hepatitis B, and that HBsAg, that's the surface antigen, it would be raised by about 2 to 3 weeks, and it can it's actually there is a it mentioned like it is a months, but it's not months, it's a weeks as such. It can be extended by about raised by 3 weeks, and it may continue for a long time, up to about 6 weeks. Then anti-HBs, another of the antibody which is present in the body, it may present for a long time, and core antibody, that core antigen also may remain for a long time in the body as such. So that the pattern of the immunoglobulins present in the hepatitis B are different from the pattern of the immunoglobulins present in hepatitis A. Now, again, this whole thing looks like a complex issue. So when you do the spectrum of immunoglobulin study in hepatitis as such, antibodies are studied, different antibodies are studied. What do you mean by that? The clinical interpretation of these hepatitis antibodies, which is again a practically clinical problem. So you will have plenty of patients who come with only HBsAg report which says that positive, and you may be having a confusion. Very interestingly, there could be many patients who may not have developed a clinical hepatitis, may have HBsAg positive, and hence they may produce often a clinical confusion. So in such cases where there is a confusion like whether the patient needs a treatment or not, it's better to have the spectrum of whole spectrum of the HBs antigen studied, and that's HBsAg is the surface antigen which has to be studied, and then the core and surface antigen HBc also may be studied. Immunoglobulin and anti-HBc, that's antidote or antibody, also can be studied, and anti-HBs also can be studied. Now, when these 4 parameters are studied, if the first 3 parameters are positive, then it's a definite evidence of acute infection. Patient, when he has acute virulent infection, the first 3 parameters are positive. Now, suppose the patient has HBsAg positive and the anti-HBc also is positive, but immunoglobulin and anti-HBc and anti-HBs are negative, antibodies are not formed, that suggests you have a chronic infection. If the HBsAg is negative but HBc is positive and HBs also is positive, anti-HBs also is positive, only the antibodies are present, then it suggests you have a resolved infection. The infection has been cleared and the patient may have some residual effects in the body. If the patient has HBsAg negative and total HBc negative and anti-HBs is positive, then it could be due to immunity, immunization, vaccination could be the cause. Now, important is, as long as the patient has HBsAg positive, that's the surface antigen positive in the body, she is a potential carrier. That patient can contaminate or transmit the disease to others. In other conditions, that risk of transmission is lesser. So whenever you go for the immunological studies, now hepatitis B, that HBsAg study has become a rather screening study for almost all persons, for those who opt for Bs or going for other areas. Even for the surgical selection of the patient, this has become a universal criteria for the screening, and hence this has some significance. So it's a need to have that clear-cut impression. Whenever there is a confusion, it's better to study the whole spectrum of the antibodies and confirm about the nature of the disease. So this is one of the issues from the clinical point of view. Now, hepatitis B, otherwise the clinical course can be similar to that of hepatitis A, but only thing is it's virulent, and moreover, another major important risk which is supposed to be there is the possibility of cirrhosis and possibility of hepatocellular carcinoma. Incidence of the hepatocellular carcinoma after the viral hepatitis B is quite significant, and particularly those patients who do have the HB virus in the body, that surface antigens in the body for a long duration, even though they do not have any developed clinical symptoms of hepatitis virus, but they are carriers. They tend to carry that hepatitis surface antigen for a long time. They are supposed to be at a risk of developing hepatocellular carcinoma, and important is there is no definite remedy for such patients to prevent HBsAg carriers. There is no remedy as such. That's about the hepatitis B. Now, for the present, it's not only the A and B. You have many more viruses which are identified, and the other viruses which are identified are C, D, and E. We will not go into the detail. Summarize. The virus C is almost the same as presented with the B virus, and the incubation period is longer, like 2 to 33 weeks, much longer than the others. And the transmission is usually mainly through the parental, from the mother to the child, and hence it has more of an obstetric interest. Hepatitis D produces again a severe liver damage and very high mortality rate. It's also usually co-infected with the HB virus, B virus. B virus and D virus, they tend to coexist together in majority of the patients, and the incubation period is again much longer, like 6 to 26 weeks. Then hepatitis E is again mostly in pregnant women, and it's usually transmitted to the oral mode as in case of the A, and may not produce a chronic disease. Mainly the pregnancy, it's a high risk. So these are the other variants of the virus hepatitis. We will not go into the details of these as such. Now, from the practical clinical point of view, I would consider all these hepatitis as such, viral hepatitis conditions, as a pitta jwara, and the clinical symptoms of pitta jwara are the same. Vegah, Tishnah, Atisarascha, Nidralpatvam, Tathavamihi, Kantau Samkanasanam Pakas, Svedashtriyate, Pralapo, Utrakata, Murcha, Daho, Madastrija, Pita Vendmutra Netrutam, Petike, Brahmayavacha. And majority of these conditions can be managed with the Mrityunjaya Arogya and Kumariyasa, except in fulminant. If the patient develops a fulminant hepatitis, this treatment may not be possible. In all other conditions, there is no need of specific antiviral therapy, and the patient can be much more effectively managed with this line of treatment. But only thing is, you have to watch for the fulminant signs, and fulminant signs require other intervention. In addition to this primary basic treatment, the other parts which you have to consider are the hepatoprotective diet has to be done, physical rest, physical activity has to be minimized, and that's the important issue about the hepatitis as such, one of the common conditions of hepatitis. Now, very rare variety of the hepatitis is autoimmune hepatitis, very rarely seen conditions. Of course, very relevant because just a few months back in October we had a patient of autoimmune hepatitis, so I refer to that issue. Otherwise, autoimmune hepatitis is a relatively rare entity, and there again the exact causes are not known as in any case of the autoimmune conditions. The clinical symptoms are very vague, like fatigue, upper discomfort, abdominal discomfort, pruritus, anorexia, myalgia, and the jaundice may not occur in a large number of patients till very late. So initial symptoms are very vague, which can give you a lot of confusion with other diseases. Only when you do the ANA studies, it may be confirmed. Only when the patient develops jaundice or hepatomegaly, which is seen in about 83% of patients, hepatomegaly is seen, jaundice in 69%. The others like splenomegaly, ascites may occur in around that range of percentages as you see in the screen. In such conditions, virtually there is none of the treatment can help. It has to be corticosteroids which have to be given in high doses that can save the patient. Corticosteroids can have a high resolution entity, or at the end it could be the liver transplantation which is required. So with this we will conclude about hepatitis. The next part is about alcoholic liver disorder, which we discuss in the next session. If there are any questions, I think I will try to answer, then wind up. Right, okay, there are no questions, so we will continue in next session.